And she has come all the way from India, where she's the professor of anesthesiology at the Postgraduate Institute and Medical Education Centre. So we're going to be very strict with our presenters this afternoon. They have 15 minutes and the beep will go off. Because obviously we're heading towards the cocktails and we don't want to be late. So I'll hand you over to Lolita.
So without wasting time, I call upon our first speaker, Ruth Zaslansky. She's a neurophysician trained at Israel, and she's presently working at the University of Vienna, and she is a scientific manager of Pain Out program. She's out here for Pain Out data as agent of change, a case study. All over to you.
2012, John Loser published an article in Clinical Updates, ISP Clinical Updates, and he said that lack of evidence about appropriateness and effectiveness of pain interventions is one of the five major crises in pain management today. And I think this is one of the, this is the wrong version. Anyway, sorry. And I think this is one of the statements that spurred the development of projects like Pain Out. Pain Out is basically a network, an international network of clinicians and researchers whose aim is to improve management of postoperative surgery, postoperative surgery through quality improvement and research. And basically, Pain Out aims to provide clinicians with tools for assessing appropriateness and effectiveness of care. Pain Out was set up in 2009 with money from the European Commission. Now that funding has ended, the project is continuing as academic, non-profit, and we keep data collection is ongoing, and even without EU funding, the project is continuing. So that the database has about 42,000 patient data sets today in the repository. So how does it work? Basically, the project is international, so we have collaborators from different countries in the world, whether it's Europe, a few sites in America, Southeast Asia, Africa. In each site we have a principal investigator and one or two surveyors who are trained to collect the data. They give a patient outcomes questionnaire to patients on the first day after surgery. The patients fill in the questionnaire in their own native language, and in parallel, surveyors abstract demographic and perioperative variables from the patient's chart and input all this data, the patient-reported outcomes and the clinical variables, into one repository, into the database. And this is when the analysis can start. Either immediate, well, then I'll show you the analysis in a minute. So the analysis can be web-based, clinicians can assess their findings immediately, or offline analysis, which is, can be much more detailed. The patient-related outcomes questionnaire has addresses 6 domains related to pain, pain, severity, interference of pain with function, whether it's in or out of bed, the negative affects due to pain, anxiety and helplessness, and some adverse effects mostly related to opioids or anesthesia. Patients also are asked to assess their perceptions of care, such as they're asked if they would have wished for more medications they received. Here you have a list of the different languages that the questionnaire has been translated in. So if the source questionnaire was in English, we now have, I think, something like 16 different translations into Arabic. What are the more esoteric translations? Malay, Danish, Mandarin, Russian. If we have a new collaborator who joins and the country, the language in the country doesn't exist yet, so we carry out a formal translation. So the first way to assess appropriateness and effectiveness of care is what we call by feedback or benchmarking. Feedback would be assessing your outcomes over time, and benchmarking would be to compare your outcomes with similar patients in different hospitals. So here's an example of a screenshot. The x-axis, each box plot summarized data from one ward, and the y-axis is the 0 to 10 numerical pain scale. So you see the box on the left-hand side indicates one medical center, so its median and mean averages are pretty good, although there is quite a bit of spread. And as you go further to the right, the mean scores of in each of these wards get progressively worse. So, exchange of information. So we had collaborators from this ward. This is reported outcome related to worse pain. So the clinicians in this ward felt that their outcomes were not so good. And they contacted us and asked us if they could communicate with these clinicians and see what sort of clinical processes they were doing, that their outcomes were pretty good. So this has ensued in quite an active email exchange. I mean, the details are absolutely not important. And they wanted to compare practices in one institution versus practices in another. What I thought was interesting, that the bottom line was that the clinicians decided that the outcomes, the worst pain wasn't so good, decided they're not going to change anything because their outcomes for adverse effects were better than those in this slide. So basically, I think one of the problems we have is we don't have gold standards of what good care is. Is good care low worst pain, or good care low adverse effects, or is good care something, a combination of patient-reported outcomes? And I'm sure that everybody of you has an opinion about this, and I think this is something that's absolutely worth discussing. Another approach for learning from the best is something we've been developing, we've recently been developing, and we wanted to do this a bit more systematically. We wanted to find wards that have good outcomes, and to learn which processes, clinical processes they were carrying out, so that they could basically use this information to convey to the wards where the outcomes were not so good. So what we did was first to identify a small set of patient-reported outcomes, so that we could identify those wards that had good outcomes versus those wards that had what I'm calling bad outcomes. I put these in quotation marks because I don't really know what the good and what the bad is, but we had to make some sort of decision for this specific study. Then we decided we'd rank these wards, and then we'd see which practices were associated with the good sides. And as a secondary outcome, we would be interested to see which practices are associated with the bad sides. So our first step was to assess which outcomes we'd be using. And we have a lot of outcomes in the patient outcomes questionnaire. There are at least 13 questions that patients answer, and so we decided to select 4. We decided that an outcome in a ward is good if the high proportion of patients report 4 or less on worst pain. We decided that outcomes were good if a high proportion of patients on a ward had a high proportion of relief. Another criteria for good outcome was if patients spent a relatively low portion of their time in severe pain on the first consultative day. And lastly, if patients said no to wishing more pain medication. Then our next step was to rank the wards, to summarize, to see which proportion each of the wards we were looking at fulfilled these criteria, and then we made a sum, and then could rank the different wards. This I'm going to skip because we don't have time. And the last step in this method, in this small study, was to select patients undergoing one procedure, and we decided to focus on total knee replacement, and we wanted wards that had at least 40 patients in the repository for this type of procedure. So the results for this part of the study was we had in the repository, in the Pain Out repository, we had 45 centers who contributed data from patients after total knee replacement. But out of these we found 14 centers with at least 40 data sets. Total knee replacement was a sole procedure, and so we ended up with just over 1,000 patients. We ranked these 14 sites and gave them the patient's score, each ward a score, and we selected the good sites would be the ones that had two sites with the best scores, and the bad sites would be those with the lowest scores. So we had roughly 200 patients regarded as good, and roughly 200 patients regarded as having bad outcomes. So the next phase of the study was to address our primary outcome. Which processes are associated with the good sites, and the secondary was which processes are associated with the bad sites. We wanted to carry out the logistic regression, with quality being our criterion variable, and we had 10 treatment processes as predictors. We selected these processes based on guidelines. We were using Prospect for total knee replacement, and we also looked at the descriptive analysis in our sample for some of the processes. So just as an example, with regards to type of anesthesia, we found that the bad sites had a very high proportion of combined anesthesia. So they used, for total knee replacement, they used a combination of general anesthesia and regional anesthesia, whereas a high proportion of the good sites used only regional anesthesia. Which types of blocks? Good sites are blue, bad sites are green. Invariably, the good sites used spinal anesthesia, and the bad sites used either spinal, much lower proportion of spinal, femoral, and sciatic blocks. We looked at perioperative opioids, the different stages. Interesting, again, we have the green columns of the bads and the blue columns of the goods. So it's interesting to see that the high proportion of the bads received opioids. I'm going to have to really race. Non-opioids were used a high proportion by the goods. Measurement of pain was used basically all the goods measured pain. Only half of the bads measured pain. For our logistic regression, we found that it was a good and significant fit. So we think these are basically the right sort of predictors. We wanted to assess the impact of the predictors in the logistic regression. We were using odds ratio as an effect size. We keep on discussing the issue of clinical significance versus statistical significance, and we're using effect sizes to assess clinical significance. And from our point of view, if the odds ratio is a medium or large effect, then we regard this as being clinically significant. So looking at our different predictors, you can see that in the goods, pain measurement scored high, non-opioids scored high, spinal blocks and femoral blocks scored high. One of our problems is that we found that the confidence intervals were a large range of confidence intervals. We're still not clear why this is. Does it indicate small precision of our indicators, subgroups of patients, not enough patients? We're not sure. This is something we still have to work on. Something that was very perplexing was the finding that measurement of pain is indicative of good care. In many our publications and quite a few from the USA have shown there's no real correlation between assessing pain and good management. So we were very surprised to find this contradictory finding with this data. Limitations, as usual, this is an observational study, convenience samples, sites not representative, so it's very difficult at this point to generalize findings. And all this data is unfortunately only from the first part of post-operative day. This is real world data. We're trying to use this data to see what we can do and how to convey this information and how to change practice. We have to carry out more work to better understand which treatment processes lead to good and good quality and bad quality. We're now trying to apply the same methodology, slightly changed to cesarean section. I must thank the collaborators in this study. This is Chapman from Utah, Komann, and Winfried Meissner from Perioperative. Thank you very much.